oligodendrocytes, okay? Oligodendrocyte cells are the one that myelinate the CNS, right? Schwann cells myelinate PNS. Now, it's a subsequent axonal damage, and they come with a unique finding, which will be optic neuritis, folks. Now, what is optic neuritis? It's a painful vision loss, monoocular, single, okay, one side. That's optic neuritis. And then they also have some brainstem cerebellar lesions, especially INO. INO stand for intranuclear ophthalmoplegia. Okay, intranuclear ophthalmoplegia. It's a lesions in the eye. I will talk about that separately on the eye section in the back of the neuro. So that's that. Pyramidal tract demyelination. That should make sense now. Okay. See, what tract are they meaning? Pyramidal tract mean corticospinal tract. Is that clear, folks? Because corticospinal tract crosses in the pyramid, isn't it, folks? So that's why it says weakness and spasticity. Why? Because these are upper motor neuron lesions. Is that clear, folks? All right. Now, these people also get some spinal cord syndrome, electric shock-like sensation along the cervical spine or neck flexion, right? So this is something we do it on the physical exam. When they come, we ask them to sit on a chair, we apply pressure on the head, and we bend flexion front. When they do that, it hurts. We call that Lhermitte sign. That's a name for that sign, okay? But it's just a pain like an electronic shock. Now here, neurogenic bladder, highlight that. When you see neurogenic bladder, what's another name? It is urge incontinence. Remember that, folks? Some first aid has a problem. Make sure it's urge incontinence. Okay, so that's neurogenic bladder, some sensory manifestations, folks, okay? Symptoms may exacerbate with increased body temperature. So these people with multiple sclerosis, no hot bath and exercise, and they cannot do anything that increases the body temperature. Relapsing and remitting is most common in clinical course. Most often affects female in their 20s and 30s. More common in individual who grew up further from equator with a low serum vitamin D level. That's one. Now, multiple sclerosis, one of the unique thing, it demyelinate all the central nervous system, isn't it, folks? So that means they affect every single cranial nerve, except one cranial nerve. There is one cranial nerve it does not affect. Anybody want to try? Type it up if you know. Let's see. There's one cranial nerve multiple sclerosis cannot affect. The answer is olfactory. Why olfactory? Because olfactory don't have a myelination. That's the only cranial nerve without myelination. If you don't have a myelination, there's nothing to attack. Is that clear, folks? So you should know multiple sclerosis people would never lose smell. They always can smell, folks, okay? So that's multiple sclerosis. Now, what are the findings? Increase IgG level and myelin basic protein in the CSF. Oligoclonal bands are diagnostic. These are oligoclonal band, right? So what are these? These are the ruptured oligodendrocytes while they were myelinating, folks. Okay, that's why. MRI is the gold standard. We could see some periventricular plug. Multiple white matter lesion disseminated in time and space. Some students get confused. What is this time and space they are talking about, right? Now, let's say here, time and space. Okay, so again, we'll do with space. It doesn't matter. Space and time. So what is this exactly? Some neurologists, like so many years ago, 50, 100 years ago, they came up with an easy way of diagnosis multiple sclerosis. So they came up with two things. Whenever patient comes with the symptoms, they were looking into space and time. So what is space? In brain, how many areas they have the lesion? So space, what are the areas? They have the lesions, folks, okay? Some people say they have 1 lesion, some people they have 3 lesions, some people say they have 5 lesions. It's a number of lesions in different part of the brain. That's space. Is that clear, folks? Okay, so space mean how many lesions you have, folks, okay? How many, okay? Or you should know that, that's the answer, how many. That's space. Timing mean how fast or frequently they started getting this lesion. Is that clear, folks? How fast and frequently, how fast and frequency. So they kind of keep watching. When a patient comes with it, they kind of keep taking MRI frequently. If they see there is more number and also they are coming very fast, so the space and time is increasing. Is everybody clear, folks? That's that space and time. There's not anything complicated there, okay? Space mean how many, what are the different part of the brain you have the lesion. Time mean how frequently and how fast you can. Now, I could give you a good example. Let's say I have a patient coming in January, have only 1 lesion, okay? 1 lesion. Then I'm rescanning the same patient in May, they have 3 lesions. Which one increased, space or time? Space increased it here, right? Space increased it here because there's 3 lesions. That means 3 different areas, folks, okay? That's the idea, folks, 3 lesions, okay? Now, once you confirm space, then they also keep an eye on the time, because let's say now, May, they got 3 lesions. So that means, of course, January to May, there's a 5 months. That's also time. So time is also playing a role. Is that clear, folks? Now, this 3 is becoming 6. Let's say July. That's even fast because 2 months. So time is increasing rapidly here. Does that make sense, folks? So space and time. So whenever it comes to diagnose a multiple sclerosis, space and time, they keep an eye on both, how fast both are increasing. Is that clear, folks? It tells the prognosis, how fast patient is developing those symptoms. That's what space and time mean. Is everybody clear, folks? Okay, so that's that. So space mean area, time mean frequency. Now treatment. Stop relapses and so slow progression with disease-modifying therapies. We give beta interferon, glutamine, natalizumab. Highlight, natalizumab is one of the famous medication for this. We treat the acute flare-up with the IV steroid. Whenever a patient have acute attack, they come to the hospital, we just give them IV steroid, complete it, send them back. They might come back after 6 months, give them steroid, send them back. That's what it is. If not, symptomatic treatment. So if they come with a neurogenic bladder, we give medication according to that. Look at that, muscarinic antagonist. What is urge incontinence? Random contraction, isn't it, folks? So we give muscarinic antagonist for that. We could do botulinum toxin, muscle relaxant for spasticity. Those things we could do for multiple sclerosis. So that's the treatment. Now, if you see, there is no cure for it. It's all about treating symptoms and slowing down the progression. Is that clear, folks? That's multiple sclerosis. Okay. Now, all right, let's move to the next disease. Now, before I do the first one, I actually want to do the second one. Guillain-Barré syndrome. Now, why I want to do this? Multiple sclerosis is a demyelination of central nervous system. This is a demyelination of peripheral nervous system, folks. That's the only difference. So this is a problem of Schwann cells. Multiple sclerosis, problem of oligodendrocytes. Is that clear, folks? So one example for each, okay? That's why it's very important. So again, if you have a problem that you are attacking all the myelin of the central nervous system, multiple sclerosis. If you have an attack of myelin of the peripheral nerve, that's Guillain-Barré syndrome, folks, okay? Similar part. Now, this is what they say, molecular mimicry, triggered by some other stress. So what exactly happened, folks? Let's say people who had this Campylobacter jejuni, that's very close association. I had Campylobacter jejuni and I recovered. Now my body created an antibody. When my body becomes stressed, immunosuppression happens, This antibody is going and attacking Schwann cell, thinking they are Campylobacter jejuni. Does that make sense, folks? So that's basically confusion. Antibody got confused between my Schwann cells and Campylobacter jejuni. So they're attacking my tissue, thinking they are the bacteria. Is that clear, folks? That's why it's called molecular mimicry, folks. Okay, that's the idea. Now, no definitive link to any pathogen. There is not a particular organism you could tell that causes this disease. That's the idea. Okay. Results in symmetric ascending muscle weakness and paralysis. This is very unique finding, folks. What does that mean? Symmetric ascending. From the leg, all the problems start ascending symmetrically, bilaterally. Okay. So they start from the toes, and then if you go to leg, thigh, hip, abdomen, they come like that, folks. The minute it involves abdomen, the next thing they used to ask, what is the next step? If they have Guillain-Barré syndrome already reached abdomen, we intubate the patient right after that. Because if it has already reached abdomen, the next thing it's going to go affect is diaphragm. Is that clear, folks? Once they affect the diaphragm, the patient cannot breathe on their own. So we intubate them, and we have them on artificial incubation, machine ventilation. And once they recover, we could bring them back. So that's not a problem. Okay. So that's the idea, folks. Now you could see here, facial paralysis, bilateral, respiratory failure are common. See, that's the idea, folks. So because it's an ascending paralysis, it's going to go slow, folks. Okay. Now, may see some other autonomic dysregulation, cardiac irregularities, hypertension, all these things. But most patients survive with good functional recovery. They come back, folks. Okay, that's the idea. Is everybody clear with this disease? Okay, now how do we diagnose? Increase CSF protein with normal cell count. So the cell count is normal, protein is high, so they are not matching. We call that albuminocytologic dissociation, okay, which means the protein and cytology is not matching. That's the idea. Respiratory support is critical until recovery. And then we could give some plasma exchange or IV immunoglobulin, but no role for steroid, folks. This patient will not get help with any steroid. So that's Guillain-Barré syndrome. Guillain-Barré syndrome and multiple sclerosis, super high yield for step 1, folks. Okay, important. Now, next. Osmotic demyelination syndrome. We used to call this central pontine myelinosis. Okay, central pontine myelinosis. Massive axonal demyelination in pontine white matter. Secondary to rapid osmotic changes. Most commonly, iatrogenic correction of hyponatremia. So what does that mean? If a patient has low sodium, let's say patient has hyponatremia, you have to treat. So what's the treatment? Treatment is to provide sodium. Is that clear, folks? So when you give sodium, it needs to be given slowly. There is a very slow, there's a calculation there that how fast you can give. Instead of giving it slowly, if you give fast, this is what happens, folks. So anybody who developed osmotic demyelination syndrome, that should tell you that they had a low sodium. Somehow they gave a sodium too fast. Is that clear, folks? That's the key. Now it gives you acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness, and it can cause locked-in syndrome. What is locked-in syndrome, folks?
Is it when you cannot move your hands or legs or your body, but you're like you can move your eyes and you're awake?
Basically, you could only respond with your eye. None of the part of the body works, folks. Okay, except nothing works. So that's a locked-in syndrome. Okay, good. So they could cause that. Now, see, that's why you have to be very careful. Now, this sentence, right? So what they are saying is, if you have a low sodium and treatment, sodium fast, you give sodium fast, you get osmotic demyelination syndrome. Is that clear, folks? What about opposite? If a patient has increased sodium, what is the treatment anyway? Water. Is that clear, folks? Fluid, right? If you give fluid, right, I'm going to say 0.9 sodium chloride, that's isotonic. If you give too fast, even fluid has to be given slowly. If you give too fast, you get cerebral edema. Is that clear, folks? So 2 diseases. So if you see a patient with osmotic demyelination, then you should know they had a low sodium. Somehow they gave too fast with high sodium. If they have cerebral edema, they must have had high sodium. They gave saline too fast. Is that clear, folks? Right? There's a calculation. That's why if you see old days, when they give a saline, they have to set it up how the drops comes, how speed it goes, right? Now it's all automatic, right? Computer machine, that's the best. You could set up the timing, the speed of the fluid. So that will send the fluid according to that, folks, okay? So that's this. Is everybody clear here? All right.
Absolutely. So can you say patients who have SIADH have a high risk of getting this or no?
Yeah. But remember, when they have a SIADH, they are reabsorbing their own water in the body, right? Because that means they could only reabsorb whatever the fluid they have. They cannot take it more than that. But here we are giving from outside. That's why. Okay. Now, next one. Not high yield, but we need to know that. Acute disseminated encephalomyelitis. So it is basically multifocal inflammation and demyelination after infection or vaccination. So some people can get this with the infection or vaccination. Patient with rapidly progressive multifocal neurological symptom, altered mental status and stuff. You're not going to get a question on that, but you should know that name. Charcot-Marie Tooth disease, folks. This is also called hereditary motor and sensory neuropathy. So that means they're going to come with a pure motor and sensory problem, nothing else, okay? Group of progressive hereditary nerve disorder related to the defective production of protein involved in the structure and function of the peripheral nerve or myelin sheath. So it's about the nerve problem, okay? So there's a protein that forms the nerve or the myelin sheath. Typically, autosomal dominant associated with deformities, pes cavus. This is the second disease in neurology. We are coming with pes cavus, so you cannot miss that. Okay, so if they are mentioning pes cavus, but they are not talking about hypertrophic cardiomyopathy, they are not talking about the other 3 tracks, you should know, then it's not Friedreich's ataxia, it's this disease, folks. Okay, that's the idea. Lower extremity weakness, sensory deficits, all these things, folks. Okay, so that's this disease. Now, after I highlight that, this is the next high yield. I was told that pretty much it comes in most of the exam, this question, folks, especially with the JC virus, they like to ask that. Okay. Now, this is also demyelination of the central nervous system due to destruction of oligodendrocyte. Didn't we just study a disease, demyelination of oligodendrocyte? What was that? Multiple sclerosis. This is similar to that, but multiple sclerosis is an autoimmune disease, whereas here it's an infection that does that. Is that clear, folks? That's the only difference. It's a secondary to reactivation of JC virus. Usually you see it on immunocompromised people, AIDS, organ transplant, all these patient folks. Rapidly progressive, usually fatal. Now, this is where I'm going to pay attention and you have to be extremely careful. If you give natalizumab, this will get worse. So if I tell you I gave patient natalizumab, got better, that's multiple sclerosis. Giving natalizumab, make it worse, that's this disease. Is everybody clear, folks? So when you read natalizumab, you need to pay attention because they ask that way, folks. Patient was given natalizumab, the symptom got worse. That means that's a progressive multifocal leukoencephalopathy. Are we clear? That's that disease, folks. Okay, very good. Now, the last ones here. We have a Krabbe disease. These are all we studied in lysosomal storage disease, those 2 diseases. But here, in my opinion, let me highlight this one too. But those 3 that I highlighted, it's very, very important, this area, folks. Okay, that's the key here. All right. Now, I'm just going to go 1 page before. There's one small disease we need to cover. Idiopathic intracranial hypertension, that's important. Page 540. Now, this is also called pseudotumor cerebri, a fancy word for increased intracranial hypertension, folks. Increased intracranial hypertension with no obvious finding on imaging. Risk factor include female sex, tetracycline, obesity, vitamin A excess. For step 1, you want to highlight this one. Where did we come across that? Danazol. Is a treatment for? We highlighted somewhere else. Where did we come across danazol, folks? Anybody? Muscle spasm. That's your confusing fix. Diclofan, not danazol. Okay. So what is okay? I guess we'll let you guys do research and find it. Okay. It's one of the subject we did this week. We highlighted it. Okay. Now, associated with dural venous sinus stenosis, these patients comes with headache, tinnitus, and diplopia. No change in mental status, impaired optic nerve exoplasm, and it can give pupillar edema. So pupillar edema is basically a pressure that pushes the optic nerve, folks, okay? Now, when we do lumbar puncture in these people, look at that, increase opening pressure. Because the other day I said when you do lumbar puncture, you do for 2 reasons. One is to check opening pressure, the other one is cell analysis, isn't it? So this one here, increase opening pressure, that gives you a temporary headache relief, folks, okay? So that's that. Now the treatment, weight loss, acetazolamide. I think when we studied renal acetazolamide, they said that it's very useful to excrete, right? So that helpful. Invasive procedure. So if people have recurrent idiopathic intracranial hypertension, we place a shunt, folks, okay? So that means the fluid can be excreted, okay? That's the idea. Optic nerve sheath fenestration surgery, if they have to help for visual loss. So that's idiopathic intracranial hypertension. Are we clear? All right. So that's that. Let's continue. Now, let's go here. There is some neurocutaneous disorder. The whole page is super high yield. Okay. Look at the word neurocutaneous. That means nerve and the skin. So these are the diseases that they will have neurological symptom plus skin manifestation. So you cannot miss that. If you see the example, see, they have to show the skin of every patient. Okay. So first, Sturge-Weber syndrome. Before we even talk about, look at this kid, picture A. It's affecting this, but not this. Do you see that? So what nerve distribution is this? What is this called? V1, V2, V3, okay? V1, ophthalmic, maxillary, mandible. So the mandibular branch is always intact. It never involves. Is that clear, folks? That's the first thing that you should notice. So it is a congenital, non-hereditary anomaly of the neural crest derivatives. Capillary vascular malformation. It's a problem with the capillary malformation. They have the port vein stain, right? So the port vein stain is on V1 and V2. Look at this. It says V1 and V2, but not V3, folks. So that could be a good question. Which of the following fibers is intact? And they could give you V3 or the name of it, mandibular branch. They also have ipsilateral leptomeningeal angioma with calcification in the meninges, seizure, epilepsy. You know, the best way to keep it easy, anytime you involve meninges, people get seizure. Okay. Anytime you involve meninges, they will have seizure, folks. Okay. Any disease that involvement of meninges. intellectual disability, increased intraocular pressure, right? That's glaucoma. All these are symptoms of Sturge-Weber syndrome. Okay, so that's that. Next, tuberous sclerosis. You could see. Now, if you see here, it's an autosomal dominant. They have a mutation in tumor suppressor gene on chromosome 9 and chromosome 16. Hematomas in CNS and skin, angiofibroma, mitral regurgitation. So you cannot miss it because they are bringing a heart and skin in here, folks. Okay. Highlight the word ash leaf spots. And I want you guys to write it down. Hypopigmentation, not hyper, hypo. What does that mean? Look at this picture D. That particular area is lighter than the rest of the skin, isn't it, folks? Then we call this hypo. So ash leaf spots is actually looks more lighter than the rest of the skin. Are we clear, folks? All right. So that's important. They could also get cardiac rhabdomyoma, intellectual disability, renal angiomyolipoma, seizure, and you should Google later Sjogren patches. You should know how those looks like, folks. Okay, Sjogren patches. So that's tuberous sclerosis. It's a skin rash. Okay. Now, the most important, even in this section, is these two diseases, folks. Neurofibromatosis type 1 and type 2. 100% sure. One question in your exam. Okay. Now, if you see neurofibromatosis type 1 and type 2, both are 100% penetrance. What does that mean? If you have the gene, you get the disease no matter what. Okay. Now, this is the disease. Look at this, folks. You've seen a lot of the time, right? So these are, TikTok has a lot of videos of these. They keep explaining those dermatologists, right? So that's neurofibromatosis. There's NF1 tumor suppressor gene on chromosome 17. Highlight Caffarello spots. Write it down. That's a hyperpigmentation. So that's a little bit hyper. Look at the skin. They look more darker than the rest of the skin, isn't it, folks? So they are completely opposite to ash leaf spots. Is that clear? Okay. That's that, folks. Okay, so you should be able to differentiate ash leaf spots versus Caffarello spots. Okay. Intellectual disability. There's a cutaneous neurofibroma. That's that in the picture. They could even have pheochromocytoma, some other seizure, focal neurological signs and stuff, folks. Okay. That's neurofibromatosis. I don't think you guys will miss it when they show a picture or enough information. Then what is type 2? The only difference between type 1 and type 2, they're exactly same. Type 2 has hearing loss, whereas type 1 don't have that. It's the involvement of the ear. That's it. You could see bilateral vestibular schwannoma. Okay, highlight that, folks. Bilateral vestibular schwannoma. Okay, now where people go wrong, it has to be bilateral. People can get unilateral vestibular schwannoma as an independent disease, has nothing to do with neurofibromatosis. So everybody clear, folks? So this has to be bilateral. Sometimes they put a picture of the brain and you could see only one lesion on one side. So that's not neurofibromatosis. Okay, you have to have bilateral, folks. So that's the difference between type 1 and type 2. Are we clear? All right. Now the last one, von Hippel-Lindau syndrome, a disease. It's also deletion of that gene on chromosome 3. Hemiangioblastoma, highlight that, folks. Hemiangioblastoma in retina, brainstem, cerebellum, spine, it could be anywhere. And I want to highlight bilateral renal cell carcinoma and pheochromocytoma. So you cannot miss this. There was a question actually on the exam. They give a von Hippel-Lindau disease and they ask what will happen. And one of the options was polycythemia. Can you get polycythemia? You can, because renal cell carcinoma, isn't it, folks? Renal cell carcinoma secretes ectopic erythropoietin, isn't it, folks? So that would be what type of polycythemia? Inappropriate, absolute, okay? Because it's inappropriate response to cancer, and that, so they could produce, folks, okay? So that's that. That's von Hippel-Lindau diseases, folks. All right. Let's see if we can pull up some question in this. So we